Good morning. Thank you to the committee for the invitation. I'm going to be speaking about alternate access techniques in lower extremity ischemia. These are my disclosures. Increasing number of practitioners are treating below the knee PAD. Limb preservation rates increase when there's direct line flow and the more vessels are open. Tackling this anatomically challenging subset requires the development of expertise in alternate access to significantly increase the level of success. Pre-intervention planning and approach is vital. Of course, best is done prior to starting the procedure, but sometimes you do have to wait till angiography to determine what to do. Important part of the procedure in complex interventions is the pre-intervention planning reduces procedure length, reduces procedure fatigue, and improves procedure success. Decide on which access site is best for the patient. Do not automatically default to an initial retrograde CFA approach. Hostile aortic iliac bifurcations or tortuosity, consider antegrade CFA or pedal access, and be open to first starting with a pedal access. I'm pretty aggressive with sedation, so sufficient sedation should be provided so the patient is calm and still. We're dealing with very small vasculature, sometimes heavily diseased. Consider general anesthesia in situations where patient cannot stay still, may be the difference between success or failure. ACT, I personally like to maintain my ACTs on the lower side when starting my intervention, anytime I have an alternate access as an option. And further anticoagulation with ACTs above 250 can be obtained after I get all my access and proceed with angioplasty, atherectomy, with or without stenting. Ultrasound skills are key. Good ultrasound access skills for alternate access reduce access time, encourage the operator to explore alternate access sooner. Get ultrasound access in all your vascular procedures. I'm an interventional cardiologist, so for cardiology, venous, arterial, I always get access with ultrasound. The more you handle the ultrasound probe, the better. Always have the sterile probe accessible during the peripheral intervention. Just briefly, I know people believe get good at one. I believe you should be, to tackle these very complex anatomy, you should be good with ultrasound access, both on short and long access. And the long access here, you can appreciate there's a little gap in the calcium, and that's where my needle is allowed to access with ease. Pre-procedure ultrasound, I personally perform my own procedure, my own ultrasounds on patients, particularly with CLI. I like to assess the best pedal access before the procedure, the caliber of the vessels, where I can place my sheaths, in what, the tibiotibial, posterior tibial, femoral, popliteal. Is there Doppler flow when the tibials may not easily be appreciated in angiography? If the vessel is occluded, is there diffuse calcium or non-calcified segment where needle access may be easier, like the example I just gave? Having a mental picture of what the anatomy looks like will shorten the procedure time and reduce fatigue. Important considerations in PVD and critical limb ischemia and alternate access: use your imagination, be creative, always be ready and open for alternate access, even when it seems to be an easy case. Good equipment is extremely important, may shorten times and success. Be mindful of operator brain fatigue. Get your alternate access early. Understand the patient's anatomy, understand the risks of the specific anatomy of the patient, single vessel runoff, vital collaterals, how flow gets to the foot and from where. Retrograde pedal access can be very helpful in severe below-the-knee disease, particularly in the presence of variant anatomy, where sometimes you don't know this exists until you get the access. This is a patient who came in with an ulcer, admitted to the hospital with osteomyelitis. I did the angio. It seems like he has an occluded posterior tibial with reconstitution distally. The anterior tibial artery is occluded distally in the perineal at the mid-segment with a large collateral. I initially tried to recanalize the distal AT unsuccessfully, and then tried to poke at the PT thinking maybe it was there without success. So I wire the perineal, and my wire keeps, goes down, and it seems to be close to what looks like initially thought was a reconstitution, but that wire seems to be subintimal and, playing around with important collaterals to the foot at this point. So I get access in the posterior tibial retrograde. My wire goes directly into that perineal, and I cross the distal cap. My wire stays intraluminal throughout from the retrograde approach, and then I'm able to treat from above with atherectomy, balloon angioplasty, so this is a perineal with posterior dominance. My standard approach to alternate access, everyone has their way of doing it. I personally like to do micropuncture access. I use strictly 014 wires for most of my accesses. Hydrophilics are preferred. In the case of total occlusion, I like to kind of spin my wire inside and visualize it by ultrasound, and just, that hand-eye coordination is very important and kind of challenging to start, but once you get used to it, again, it's very important to do more of these and get acquainted to them. It gets easier with time. It is a challenge. And then I usually just take the needle out, and I usually start with my microcatheter if the disease is critical, and then go from there. Antegrade common femoral, some people femoral approach we might think of as a standard approach, but antegrade common femoral is extremely important, a skill for access. It allows the treatment of the pedal arch with more ease, easier manipulation of the guide wire, it's easier advancement of the equipment. I actually use one of the hospital bins, and that's what I use to cover the patient's head, and it's flat surface and it's very comfortable. So I do probably 30% of my patients are antegrade access. This is an example. The patient had an occlusion of the anterior tibia all the way down to the dorsalis pedis. I first attempted approaching it antegrade without success, so I went and advanced my Hydro ST wire, which is a hydrophilic wire from Cook, went around the pedal arch and retrograde the anterior tibial. I was able to meet both wires, the antegrade and the retrograde, with extravascular ultrasound, performed atherectomy, and recanalized the vessel. This is an example of multi-level retrograde tibial access. Again, it's a patient with anterior tibial. All these patients have, had ulcers. The AT was occluded proximal all the way down to the dorsalis pedis. I try to gain access as low as possible, trying to get the included dorsalis pedis. So this is my access at the dorsalis pedis with the microcatheter. My wire did not advance past the ankle, so I gained access retrograde right above that, and this wire was able to be advanced retrograde across the occlusion and the distal cap into the pop, advanced the wire into an antegrade microcatheter, and then worked from above. This wire was then advanced. I kept that microcatheter in the dorsalis pedis, and I was able to wire into that dorsalis pedis catheter and externalized it, and from there performed my atherectomy, balloon angioplasty. Retrograde midfemoral and retrograde perineal arteries, 72-year-old male with a very painful ulcer of first and second toe. He had multiple interventions at other facilities from different physicians. So he had a femoral stent which was occluded, a femoral perineal bypass which was occluded, and then stenting of those bypass which occluded as well. He had seen several physicians in a couple of hospitals, and they recommended above knee amputation because of severe excruciating pain and ulcer. My initial attempt via the up and over antegrade SFA was unsuccessful. It kept going into a dissection around the mid-femoral. So I gained access directly into the previously placed femoral stent with a V18 wire retrograde. I externalized it to the contralateral access sheath and worked from above. I got my wire down the popliteal region, but after that I couldn't get that wire down, so I gained access into the perineal, both for trying to get recanalized from below, but also to use a sheath for embolic protection and aspiration during a possible atherectomy, given the patient had a single vessel runoff. So I threw the kitchen sink at the guy, atherectomy with jet stream, the femoral, popliteal, and perineal arteries, a shockwave lithotripsy, superostent to the popliteal. The patient underwent first toe amputation and hyperbarics, and this is 2 years out. The patient has his leg. Flush occlusions of the SFA may present as challenging anatomy. I have on several occasions gotten access directly in the proximal SFA occlusion and advanced my wire retrograde into the sheath and then externalized the wire and then worked from antegrade up and over. Just getting acquainted with hand-eye coordination wire. I don't have a tech to ultrasound while I'm wiring, so I do everything myself. But with a little bit of practice, this is a weight tip wire for a calcified proximal cap occlusion, and able to advance the wire retrograde into the sheath and recanalize the vessel. Retrograde high lateral, just to show some other examples of where you can get access in the lower extremity tree. This is a very compromised foot with a posterior tibial occlusion. Some bridging collaterals. I was a little concerned of, messing around with those little collaterals as he was so compromised. And I couldn't get the wire anywhere. So I got access in the high lateral plantar artery. I was able to break that cap, then advance my work from antegrade and advance the atherectomy and balloon angioplasty. Antegrade mid-anterior tibial access and retrograde DP access. Again, the topic here is be creative. Any access is available as long as you do this with a safe technique. This is an occlusion of the anterior tibial artery from proximal to distal. I tried from above. I felt pretty confident that I can get the DP and retrograde. It seemed like a nice distal cap. For some reason or another, I tried for a little bit and the wire wouldn't go, so I gained access antegrade in the AT mid to distal, hoping to get that wire down and break that distal cap, which I did, advance that wire into the dorsalis pedis. Once I broke that cap with a wire, again, this is all with 014 wires I work, and I just advanced my wire retrograde from the previously placed microcatheter and worked from above. Finally, I've done a few cases of these with patients with lateral plantar access, even in the most critical disease, a patient with the AT and PT occlusions. I did work the AT antegrade, the posterior tibial. I couldn't get the wire down. I accessed the lateral plantar artery with ultrasound. And once I got the wire up, I then advanced microcatheter down antegrade and worked from antegrade and recanalized the posterior tibial. So in conclusion, improve alternate access technique, reduces procedure time, improves success. Ultrasound skills and pre-intervention planning are key. Make sure to have the best equipment at your disposal. Thank you.